Patients with autoimmune diseases will often have multiple autoimmune diseases at the same time, and one of the very classic pairings in patients with rheumatoid arthritis is Sjogren syndrome. How will a patient with Sjogren syndrome present? Classically, there's a triad of 3 symptoms that are seen. Xerophthalmia, which refers to dry eyes, but may present with patients saying they have the sensation of sand in their eyes, namely because they're not producing very many tears. Xerostomia, which means they have the sensation of a dry mouth, which can also cause dysphagia, because chewed food is just not being lubricated enough to make it easy to swallow. And the third thing is arthritis. So what's the underlying mechanism of pathology here? The exocrine glands are being destroyed, especially the lacrimal and salivary glands that give rise to 2 major symptoms. Patients with Sjogren's may also present with parotid enlargement, which occurs because it is only the submandibular and the submaxillary salivary glands that stop producing saliva, while the parotids have to make up the difference, and they compensate by enlarging. What else might you see associated with the disease? B-cell lymphomas, which are more likely in patients with autoimmune diseases as a result of chronic inflammation, which predisposes to dysplastic changes. Dental caries are also more likely because saliva has a number of chemicals that will aid in dental health, but without these enzymes, the teeth are more likely to have bacteria and significant plaque buildup. The antibodies to know for Sjogren's disease are anti-RNP, anti-SSA, or Rho, or anti-SSB, or anti-LA, with Rho and LA being the more important ones to remember. SS in the name stands for Sjogren syndrome, so that will make it easy to remember. So how will this patient present? It's likely going to be a 40 to 60-year-old woman with a history of rheumatoid arthritis. Let's have a flash quiz. What disease process is most likely to cause a patient to complain of sand in my eyes? Sjogren syndrome. Look for dry mouth, too. The next disease we'll discuss is gout, a relatively common disease that's important to know very well. You will see it on step 1 and also on the wards. And you need to differentiate this joint pain from osteoarthritis, rheumatoid arthritis, or other joint pathology. Biochemically, this disease is characterized by precipitation of monosodium urate crystals into the joints due to high serum uric acid levels. What's the gout catchphrase? Negatively birefringent crystals, or yellow crystals in parallel light. There are a lot of causes of gout, theoretically due to 2 major problems. Uric acid can either be overproduced or underexcreted, which can cause high serum levels, thereby leading to higher likelihood of crystal deposition. Of the 2, underexcretion represents 90% of cases. Do you recall from biochemistry how Lesch-Nyhan syndrome works? HGPRT deficiency causes a buildup of uric acid. Patients get that uric acid frost. And, you guessed it, horrible gout. PRPP excess also occurs in patients who have mutant PRPP synthetase, causing it to be insensitive to feedback inhibition. So what builds up? Purine nucleotides and uric acid. What about von Gerke disease? Here, you have glucose 6-phosphatase deficiency. How does it result in hyperuricemia? Well, increased levels of G6P is metabolized by the pentose phosphate pathway to generate uric acid. What other metabolite is overproduced in von Gerke? Lactic acid, which competes in the renal tubules with uric acid for excretion. Thus, for these inborn errors of metabolism, patients have both increased production and decreased excretion of uric acid. Certain medications and increased cell turnover can also result in hyperuricemia and gout. The case vignettes are always rather similar. usually with some external insult leading to a gouty flare, likely in a single joint, and most commonly in the MTP of the great toe. A classic example is a patient who is treated with chemotherapeutic drugs for leukemia, who turns over cells very quickly due to rapid cell death from the chemotherapy, leading to a huge overproduction of uric acid. This precipitates a gouty attack, thereby causing a man being treated with a standard therapy for his cancer presenting to your clinic with intense, extreme joint pain. How do oncologists anticipate this problem? By pre-medicating all patients with large tumor burdens with allopurinol, a blocker of uric acid production, to prevent it from being created and allowing serum levels to stay low. We'll go over the mechanism of allopurinol later in the pharmacology section. So how does gout present commonly? The symptoms of gout classically consist of an asymmetric joint distribution, and often a red, swollen, painful joint, most commonly the MTP of the big toe, as pictured here as well. With long-standing gout, the crystals can precipitate into deposits called tophi, or tophaceous gout. These tophi can be anywhere, but classically appear on the external ear, olecranon bursa, or the Achilles tendon. Why do the crystals form here? It's basic chemistry. These areas are just a few degrees cooler, and so crystals more readily precipitate. The tophi themselves don't really cause that many problems. It's actually the acute attacks that are very, very painful, and they don't occur at the sites of the tophi necessarily. So what will precipitate an attack? Things like large meals or by drinking alcohol, both of which allow for uric acid levels to increase. With alcoholism, as with HIV and other important chronic diseases, it's important to build a list of common complications and diseases that often present with them so that you can use it as a shortcut when you see them in a clinical vignette. This is a great one to add to the alcoholism folder in your brain, along with thiamine, B12 folate deficiency, and DTs, which you'll remember from the biochem chapter. Why does a long night of drinking result in a gouty attack? Alcohol metabolites compete with uric acid in the kidney for excretion. The treatments for this disease are varied and usually determined by the clinical presentation. What can we do for patients acutely? The goal here is